Good morning, everyone, and welcome to this webinar on how to set up your Fracture Liaison Service. My name is Anastasia Soulier, and I am the CNS and Capture the Fracture project leader at IOF, and I'm happy to moderate this webinar. Before the speakers introduce themselves, I would like to inform you that attendees are automatically muted. I would also like to encourage you to ask questions during this webinar by typing your questions into the question box of the control panel. The questions will be answered at the end during the Q&A session. I will now let the speakers introduce themselves.
A forward slide. Hello, my name is Kasim Javed. I'm an academic rheumatologist from the University of Oxford, and I'm delighted to share our thoughts on Fracture Liaison Services with you. Thank you.
Good morning or good afternoon. My name is Serge Ferrari. I'm a professor of medicine and head of the Service of Bone Diseases in Geneva, Switzerland. And I'll be also glad to share this webinar with you, and particularly our experience with the Geneva FLS.
Good morning, everybody. I'm Nabil Abdullah. I work as a rheumatology consultant here at Hamad General Hospital, and osteoporosis is one of my interesting fields, and I'm trying to learn more about how to set up an FLS clinic.
I'm Dr. Samar Al-Amadi, Chief of Rheumatology at Hamad Medical Corporation, and we are building up our Osteoporosis Center, and FLS is part of the journey that we are starting.
Very good. So let's go into our learning objectives for today. We would like to understand the need for FLS implementation in case you don't already know. We'll explain to you about how to apply the best practice framework that IOF has developed to set up the most effective FLS. Number three, we'll explain to you how to apply for global recognition of your FLS center and get mapped on the IOF Capture the Fracture map. And finally, how to raise awareness about the Capture the Fracture projects, and we'll present you the tools that are available to develop your Capture the Fracture on our website. Next slide. So just a very little background on the burden of fragility fractures, which is the reason why we need to develop FLSs. I'll go quick because you all know this data. Next slide, please. You know that worldwide fragility fractures due to osteoporosis are very common. A woman in 3 in some countries, a woman in 2, and a man in 5 in some countries, a man in 4 after the age 50 will eventually sustain a fragility fracture due to our disease, which is 1 fracture every 3 seconds around the world, and no country is spared by this disease. Next slide. You also very well know the consequences of fragility fractures. For those who are lucky enough not to die directly from the fracture, there is sometimes poor recovery, certainly disabilities that can affect the oldest old, increasing risk of second fractures, and that's absolutely the goal of the FLS, and the persistent loss of mobility and loss of independence that puts a burden on all our society with those aging people who have suffered from a fragility fracture. So for all these reasons, obviously, try to prevent the first, but particularly the second fracture will be extremely important. Next one. So the first fragility fracture leads to a very high risk of another fracture, particularly within the first couple of years, where the relative risk of a second fracture is increased several-fold when you just sustain a major fragility fracture. So the first fracture is a sentinel fracture that should alert us and lead us to start a diagnostic of procedure of osteoporosis and eventually a therapeutic approach. So healthcare institutions are often missing to respond to the first fracture in terms of secondary prevention. The underlying causes of incident fracture remain underdiagnosed and undertreated. Most people still believe it's just due to the trauma, to the accident. They don't connect the fracture with the concept of osteoporosis. And we have good pharmacological interventions, right, that have been proven to substantially lower the risk of fractures, but unfortunately, they're absolutely not used to the appropriate amount and level in the context of prevalent fractures. Next. So this is an interesting graph that puts osteoporosis in the context of a number of chronic disorders. The x-axis shows you how those disorders cause long care institutionalizations. And you see that for osteoporosis, the fractures related to osteoporosis, it is between 10 and 50% of the cause of long care institutionalization that are caused by this disease, almost as important as the hospitalization institutionalization caused by stroke and blood pressure. And then the y-axis shows the potential reduction of healthcare use with appropriate secondary prevention. And again, osteoporosis, almost like stroke and blood pressure, is at the highest level, which means that we have a disease here that is both a major cause of long care institutionalization, but for which a lot can be prevented to reduce the healthcare use. And despite that, as we know, very little is done to prevent the secondary fractures. Next. So why focus on preventing the next fracture? It seems pretty obvious, because the first fracture often leads to disability, poor recovery, increased frailty. The frailty leads then to more falls, and if we have not treated at least the underlying bone fragility, there will be more fractures, and we enter a vicious circle. Okay, so the whole goal of developing an FLS is to capture those patients and break the vicious circle as early as possible. And now I will handle the microphone to my colleague, Dr. Abdullah, to present you with the situation in Qatar.
Thank you, Professor. Good morning, everyone. So I will try to keep my talk as brief as possible so we can get our maximum to hear from our distinguished speakers, and also to get some time at the end for Q&A. So the task given to me was to present local data regarding fragility fractures. I mean, that would be like any incidence of hip fractures or other major osteoporotic fractures in Qatar, impact of the fracture on patients in Qatar, economic burden of hip fractures, any treatment care gap if it is present. So I did some search online to look for any of these data. And next slide. And unfortunately, I could not find any published data on any of the above information. So actually, I would like to take this opportunity to, so that everyone knows that we need to start cooperating with each other and collecting data, because it's really important that we look at our own data to understand what are the problems that we are facing and what kind of solutions can be planned, and also to convince higher authorities about the need for support that we need. And in a country like Qatar, with such a small population, and the healthcare being mainly by one healthcare system, it's not a tough thing to do. So my options were to present other regional data. There has been some publications from the region, but then I thought I would present something else. Next. So recently we have been trying to gather some data in order to try to get our own FRACs. I assume that most of the attendees, they know about FRACs. So to develop our own FRACs, we tried to collect some data from our healthcare electronic health records, which is the Cerner. As we all know, Cerner was implemented in mid-June 2016. So we decided to collect data from 2017 to 2019. Any hip fractures that presented to any of our Hamad hospitals were included. Obviously, we did not get data from the private hospitals, but as most of you know, the private hospitals probably they might not be having any, or maybe just a few numbers. And the way the data was extracted was the diagnosis made by the doctors. So as you know, some of you may be knowing that we have a SNOMED code. So this is how the data was extracted. And our osteoporosis team, we are a few rheumatologists who are very interested in osteoporosis, and we all sat through all those patients that were extracted, and we made sure that we exclude the high energy fractures and also malignancy associated fractures. And also we were able to get information from the ministry about the population in Qatar during those years, about 40 years. So you can see in 2017 it was 67,300, in 2018 it was 69,400. We couldn't get the 2019 data, but at least we got these 2 years, and we are waiting for the 2019. So let's look at the results. Next slide. So that's what we were able to get. So in 2017, we had 49 hip fractures. In 2018, 75 hip fractures recorded. And in 2019, 74 hip fractures recorded. Next slide. So other information, so the male to female ratio among these were almost equal. So there was actually 97 females and 101 males. The mean age of presentation was 70 years. The most common hip fracture was the neck of femur, followed by intertrochanteric fracture and then subtrochanteric fracture. Out of the total 198 hip fractures recorded during the 3 years, there were 2 patients who had 30-day mortality, and there were 5 with a 1-year mortality. The average length of hospital stay was 10 days, with a minimum of 1 day in patients who went against medical advice to a maximum of 77 days. Next slide. So this was the record of the nationalities presented for the year 2019. So the majority of the patients were Qatari, followed by Indians, then there were Palestinians, Egyptians and Sudanese, a few number, and then the others. Next slide. Okay, so this was the alarming thing that we found, that out of the 198 patients recorded during the 3 years, there were only 26 patients who received a DEXA scan after the fracture, and there were only 20 patients out of the 198 who actually received any kind of treatment. So that would come around 11%. But even in the 20, there were many patients who maybe received treatment only during the admission, or a 3 months follow-up or 6 months follow-up, and then they lost to follow-up. So you can see that the far less than 10% is only patients who actually received long-term treatment. So definitely we can see that we do have a problem, and it needs we need to find solutions for this. And this is one of the reasons that we got motivated to plan an FLS program in Qatar. And so as part of that plan, we decided to have this webinar meeting to hear from our distinguished speakers. And at the same time, we have already planned to open an FLS clinic in collaboration with our orthopedics center at Bone and Joint Center. So hopefully the next month, first week, we will be opening this clinic where we plan to capture all the patients who present there with fragility fractures and start treatment for them. I have one more last slide, which is actually, next slide. Sorry, this is another slide that we found that just for the year 2018, you can see that there were 75 patients with hip fractures, and out of them, 14 patients actually had already a previous fracture. So you can see that 8 patients, they had their other hip fractured earlier, 4 of them had vertebral fractures, 2 of them had distal radius fracture. But in spite of that, majority of these patients never received an evaluation for osteoporosis or received any treatment. So definitely a problem exists, and we need to find solutions for these. Next. Next slide. Yeah. So this is actually another data that I just received 3 days back. This is for the same year, so 2017, 2018, and 2019. But this time it was diagnosis recorded by the clinical coders. As you all know, that we have clinical coders who sit and record all the diagnoses. So here actually you can see that the numbers were much higher. In 2017, there were 168 hip fractures, followed by 172 and 182. So it seems that this is going to be a more accurate data. And then our osteoporosis team, we will try to sit again and do the work of trying to gather information from these two. And hopefully then we will come out with, but definitely from the other data, we already know that we do have a problem. And hopefully by implementing this FLS program, we can really benefit our patients. Thank you. Now I'll hand over to Professor Qasim.
Well, actually, I'll hand over to Cass as well, because thank you very much, Dr. Abdullah, to have presented us with the potential size of the problem in Qatar, like in many other countries. So we now know the problem in busy hospital systems like the one you presented. How do you make sure all the right patients with a broken bone get assessment and treatment to lower the risk of another fracture? That's the magical approach and target and goal of an FLS. And so Professor Javaid will tell us how they solve the question or the problem, at least in the UK. Cass?
Thank you very much, Serge. So could I have the next slide? So this is, as Serge mentioned, this is a global problem, and policymakers and clinicians around the world are focusing on this, and they're coming up with very similar solutions. So this is a solution that was actually proposed by the orthopedic community in the UK almost over 10 years ago. And it was to have a stepwise implementation. You can see the red arrow showing the stepwise implementation. And the first step was to make sure that the inpatient care for hip fractures was prioritized. And then following that, making sure that the patients were operated quickly and had appropriate rehabilitation, the focus was then placed on secondary fracture prevention, above primary prevention in green and healthy aging in blue. And the reason for this is very simplified in this schematic, and it shows roughly what we expect, that half of the fractures are coming from people who've already had a fracture. So half of your hip fractures are coming from those people who've already had a recent fracture. And I note that Nabil already pointed out that 20% of his hip fracture patients had a recent history of fracture. And if you look harder and include vertebral fractures, that proportion does go up. And you can see by taking this approach, you only have to focus on 16% of the population to try and address the risk in half of all of your patients. So policymakers like this approach. It focuses healthcare resources to be delivered efficiently. Next slide. And this is a crucial slide when you're setting up a FLS, either at the patient level, doctor level, or policy level, because it encapsulates in one figure the entire process. So we start on the top left with the healthcare system. The key is to have a system that identifies high or moderate risk fragility fracture patients. And we usually use age and fracture site to do this, such as age over 50 or fracture sites that exclude the digits, scaphoid, face, and skull. And then you have to have a system that can rapidly investigate patients for two components. Number one, exclude reversible secondary causes. And number two, assess their fracture risk so you can give them appropriate osteoporosis treatment. And that's really important because we're now living in an era where we can personalize the treatment based on risk and give people at moderate risk a different type of osteoporosis treatment compared to those at high or very high risk, as Serge has published and many others have. Once you've made the recommendation, the key is to get people started on treatment quickly and staying on treatment. And this often involves coordination with primary care or other healthcare professionals outside of the hospital setting and varies by global healthcare system. It's only by making sure enough patients are identified, rapidly initiated, and stay on treatment, you can actually achieve the reduction in fractures that then leads to a reduction in secondary care admissions and long-term care admissions that will give you the healthcare benefits that justifies the prioritization of fracture liaison services. A key additional component that's becoming more and more apparent, and Serge will discuss this when he presents his Geneva FLS, is the need for service improvement. We know when many FLSs are set up, they're starting, but they need to focus on improving if they're to deliver their benefits. So next slide. And what are these benefits? Well, you can look at data. This is from a literature review published 2 years ago, and it gives you a very rough idea of, if you put an FLS in, what are the expected changes in testing, adherence, initiation, as well as potential reductions in absolute refracture rate and potential mortality. These are global estimates, and what we really need to do is work out at the country level what would be the impact of a secondary fracture prevention service such as an FLS. Next slide. So what my colleagues, especially Dr. Rafael Pinedo Villanueva at University of Oxford, and Professor Cyrus Cooper, Oxford and Southampton, and the team at the IOF have done, is that we've developed an FLS calculator. And at its face value, it's very simple. It compares the impact of current practice versus FLS on a whole number of key outcomes, including refracture rates and then the subsequent effect on admissions, procedures, bed days, and care home admissions. And then using national data on costs, we can then work out the costs averted from having an FLS, as well as the costs of an FLS. And we've just completed the first round of this data for Japan, because we've been working with them for a few months, just to give you an example of what it could look like. Next slide. So Japan is a much bigger country than Qatar, with a population of 120 million. So the numbers are much bigger than we would expect to see in Qatar, but it gives you a flavor of what we're looking at. So if we take the population of Japan, we estimate there are 1 million fractures every year. And on the top bar, we have current status, and on the bottom bar in blue, we have what we think will be the target achievement from a good post-fracture care service. So for current service, we have 20% of people identified and 20% treated. I know from Dr. Nabil's presentation, it was only 10% treated, so you have a bigger gap. And then the computer model works out the expected number of fractures by 5 years. And then it does the same model again, but instead puts the 1 million people through a fracture prevention service with a much higher rate of identification and treatment. And here you can see the total number of fractures over 5 years is 200,000, giving you a saving of 20,000 fractures per year. And I must remind you, this is for a much bigger population than we have in Qatar. But you can see what you can do with this data. You can then feed back to policymakers the number of bed days avoided, operations avoided, and clinic appointments avoided, as well as long-term care home admissions. And when you combine these events, you can come up with the cost saved at the hospital level and also at community and social care level. And then you can compare this with the PFC costs. We know how many patients the PFC is seeing, and we ask our key opinion leaders, how long does it take to identify, investigate, treat, and monitor a patient? And they can then come up with a scoring for the staff costs, both for administrators, nurses, and doctors across this pathway. We also know relatively how many people are having DEXA scans and laboratory tests, and we can work out the cost of the PFC. And then we compare the cost of the PSC with the cost saved, and in this case in Japan, it gives you a net saving of just over 5.5 billion yen. Now, this doesn't include the drug costs. The drug costs are often separate from the cost needed to set up an FLS, so we do provide the drug costs separately, and here you can see them here at 236 billion over 5 years, and this compares very favorably for drug costs for other long-term conditions, such as dementia, that affect other countries. So you can see in one image, one infographic, we can give a very high-level summary of the achievement of a PFC in terms of benefits for the national hospital system as well as the wider healthcare system. Next slide. So many of you are now thinking, wow, this sounds really exciting. How do I get started? So on this slide, I've mapped out the key steps for getting started. The first step is to build your team. Often it's an individual who starts the idea of an FLS, but it's a long journey and you need friends and you need colleagues who will help you to develop your FLS in your hospital. This is very important. As well as you can see on this graph, we have the specialists that may be radiologists, orthopedic surgeons. You may also need to connect with other specialties such as falls prevention and people who are involved in long-term maintenance of therapy, which may be primary care. A key player in your team are the patients and carers. They will work with you to help develop your team, and they'll also provide you with the motivation to keep going when in the first or second instance the payer says no or not yet. For example, in Oxford, it took us 3 years to set up an FLS, almost 10 years ago, and it was only through the persistent work of the patients and myself we actually got it funded. So once you've got your team together, look for help. Link to a network or a coalition for support. You may have a national or local osteoporosis or rheumatology service or endocrine service or orthopedic service that can help you. But also, as we'll describe later, there's lots of information available internationally, such as on the Capture the Fracture website. So what do you actually need to do when you get started? Well, there are 6 key steps you need to go through. The first is to map your care pathway. Map where hip fractures, other inpatient fractures, outpatient fractures, and spine fractures go through your hospital system. This is critical because it shows you where your FLS may find patients, but it also gives you an idea of the volume of patients and where they are. And this helps you with step 2, which is designing your target FLS pathway. It sounds simple, and it usually is if you work with the patients. There are 2 key priorities here. Number 1, keep it simple. Some of the patients will be extremely frail, and having to come back and go to hospital may be troublesome. And with COVID, there's even less face-to-face contact, so you have to think of going remote. And the second principle, after keeping it simple, is to keep it fast. You need to get people onto treatment as rapidly as possible. As Serge has already pointed out, the imminent risk of fracture is many-fold higher in the first 2 years. And if you're waiting 6 months or 4 months for the DEXA scan, you will have missed many fractures. And remember, taking oral treatments to reduce non-vertebral fracture usually has a lag time between 6 and 12 months of onset. So you can quickly start people on treatment, and by the time the drug works, their imminent fracture risk is already passed. The third step is to pilot and improve. You're trying to put another pathway into an already established healthcare system that is already very complicated and often very, very busy. So there may be some assumptions you need to test, such as when is the best time to identify patients, when's the best time to assess and recommend, and who to recommend to. So test these in a few patients to make sure that the plan you put together is robust. Once you have your pathway and number of patients, the next step is to work out your costs. How much doctor time, nurse time, administrator time? Do you need a database or digital tool to support your patients? And then work out the expected benefits by looking at current practice and the expected reduction in refractures you'll have with your PFC. This will then lead to what we call a business case or a proposal you can take to your managers, and the complexity and its length will vary by hospital and also healthcare setting. This works both in public and private healthcare systems. The final step is to work with your local and national network in step 5 to get endorsement and say, yes, this is the right way forward. We can do this, we have help from others, and we think it's a priority for patients. And once you've delivered it, the next step is actually to get your FLS started. And on the next slide, I'll highlight a key component of this, which is called stepwise implementation. Next slide. So don't think you can start your FLS in one go. It's quite a complex procedure from identification, investigation, recommendation, and monitoring. So what we recommend is a stepwise implementation. Budget that by the end of the day you will find all your fragility fractures, but actually acknowledge that in the first instance it's often easier to start with hip fractures, get the pathway working in hip fractures, then extend to other non-hip fractures that are admitted to hospital before finally going to outpatient fractures. Once you have all of these easy to find fractures going through the whole pathway with good rates of monitoring at 4 and 12 months, you can then think about including spine fractures using either clinical spine fractures or radiological spine fractures. So I've given you a theoretical model of how this might work. Now let's hear how it's worked in Switzerland with the Geneva FLS from Serge Ferrari. Serge, over to you.
Thank you, Cass. Yeah, so just a few slides I'd like to share with you our experience from our own FLS that, as you see, has been established about 20 years ago. The first point I'd like to make is that, like Professor Javad already mentioned, you have to start with the little means that you can put together, not necessarily hope, no wait that your hospital or government will give you all the necessary means from scratch. We have had to support our own FLS with our own funding for more than 10 years before eventually the hospital gave us the salary of the coordinating nurse. So you have to start somewhere and prove yourselves that you indeed can do it, sometimes without a lot of internal or external support. So it really requires a champion and a continuous effort to get it started before it eventually gets recognized and fully supported. That's the first point. Be resilient. Next slide, please. So, like Professor Javad again mentioned again, when you look at your burden of fractures in your hospital, you're going to see that there are a variety of fractures that come in, typically the hip fractures and then the non-hip, non-spine fractures, and eventually the vertebral fractures. And not all of them go to surgery, of course. Hip fractures go to surgery by definition, but the non-hip, non-spine, the other peripheral fractures, only a proportion goes to surgery, the other will be conservatively treated. And the next step is then when those patients come out of surgery or when they've been treated conservatively, the follow-up care could take place in very different instances. Some will be released home, some go to a rehab clinic, others in our case go to the geriatric rehabilitation hospital. And you have to take that into account. And as Professor Javad explained, do a stepwise implementation. Don't even hope that you're going to be able to capture all these fractures at once. Go for the low-hanging fruits, the hip fracture, and then go for the non-hip but surgical fractures. And honestly, Geneva, 20 years later, we are still not capable to capture the fractures that are treated conservatively and sent back home within 24 hours. They come in, go out so fast that it's very hard to capture them in your fracture liaison service. So if you're really good, you're going to do that a few years down the line, but start with the low-hanging fruits. So how is our system organized? Next, please. Very classically, we have a coordinating nurse belonging to the bone disease service who goes every day in the surgical orthopedic ward to recognize, to identify who are the patients who respond to certain criteria. Age above 45, low trauma fracture, and those are the patients that potentially have osteoporotic fractures and need to be taken care of. And so she starts to take some medical history and then refers those patients to an intern of the service who will then review the case more completely, eventually go and see the case, and with the supervision of a senior doctor who belongs to the geriatric service with whom we collaborate, eventually they'll make a treatment plan. And the treatment plan will be, when necessary, to do DEXA and lab tests as much as possible in the hospital, and then to create a report. And with the report, a prescription and a treatment that should be potentially given within the hospital, or if not possible, outside the hospital. And for those patients whom we don't manage to have this assessment within the first hospitalization of the fracture. For example, some patients can't have the DEXA right there in the first week or so, and will have be programmed to have the examination a little later on. Then they will come back and be seen in our outpatient clinics. Now, another important component of Fracture Liaison Service is the prevention of falls. And that we have developed this program for falls assessment and prevention specifically for the patients with a fracture that will be going into geriatric rehabilitation hospital, because that's where we have the setting to do this falls assessment. So that is for the peripheral fractures. Now, next, the extra layer is the vertebral fractures. And most of the vertebral fractures in the hospital, they're silent. They are discovered serendipitously on lateral chest X-rays. So what we have set up here is an alert system in the computerized system that every time a lateral chest X-ray is performed, particularly in the internal medicine department, an alert comes to our intern, who then is going to read the X-ray again, specifically in the search of a morphometric vertebral fracture. And by doing so, we capture another layer of osteoporotic fragile patients who are those with those silent vertebral crush fractures that then enter in our assessment system in the very same way as a hip fracture. Again, we didn't do that from the beginning. We started with the hip fractures, extended to the peripheral surgically operated fractures, and our third step was the vertebral fractures. So let me give you some numbers. Next slide. Example, over 6 months this year, we had 143 hip fractures coming to the surgical ward, 230 non-hip, non-spine fractures coming to surgery. So 373 in total, okay? The coordinating nurse sees them all, identifies them all, refers them, they're evaluated. So our intern eventually recommended a DEXA scan, ordered a DEXA scan in 172. 42 additional ones had the DEXA and lab test that were recommended but could not be performed in the same hospitalization. So they were performed later and then seen in an outpatient clinic. And eventually, there were 233 of those initial patients who got the report, and 188 were treated in the hospital immediately. Now, the important thing here is, well, but you had 373 patients coming in surgery, the nurse saw them all, but at the end you only have 233 complete reports and treatment prescribed. What about the 140 that are missing here? Next. Well, you need to realize that sometimes the patient goes so fast through your system that you will not be able to completely evaluate, or you will not be able to actually start the therapy. And this is the proportion, the 140 that were referred to their GP. Our experience shows it's not the best strategy because, as you will see in the next slide, the adherence to therapy is not ideal when you just refer. So as much as you can do in the hospital and within the first shot, like right after the fracture, that is much more beneficial, but you have to admit that perhaps a third, maybe half of the patients that you will identify through your system initially, you will not be able to fully assess and treat before they leave the hospital. And then that means that your FLS does not stop at the door of the hospital, but has to extend within the practice out there with your other colleagues, maybe the GPs, who then will relay what you have studied to do. Next slide. This is now to show you about the vertebral fracture FLS system we have in place. So capturing the fractures from the X-rays. So here's a 1-year result from a couple of years ago. So in a year, there were more than 1,000 lateral chest X-ray that were performed and for which we got an alert. We set the alert only for patients above age 60 in this case. In those 1,000-something X-rays, our intern detected 184 patients with a vertebral fracture, which is 20%. And this is after exclusion of secondary causes like cancer and others. So it's an extremely prevalent fracture in a hospital setting, okay? 60% of those were grade 2 or 3. We recommended treatment in 80+% of those patients. And then we compared, because this was an observational study, two strategies. We either recommended treatment for those patients with an osteoporotic vertebral fracture. We recommended treatment in a letter to the GP, or we initiated treatment ourselves. And look at the results at 6 months. Next slide. So look at the right of the slide, 6 months, okay? The last two columns. When we started therapy in the hospital at 6 months, adherence to therapy was 54%. When we recommended treatment to the GP outside, adherence at 6 months was only 22%. So again, like for the peripheral fractures, our experience indicates that the more you do in the hospital in terms of diagnostic procedure and initiation of therapy, the more efficient your FLS will be further down the line. Thank you very much. Kat, I handle it back to you.
Thank you, Serge. And that was a really good example of some key points when you're setting up your FLS. And I hope you've taken note. Thank you so much, Serge. So how are we doing globally? Well, globally, you're not alone if you're setting up your FLS. There are over 500 FLSs now mapped in the Capture the Fracture website, and you can see the link below. And you can see we've got a bit of work to do in Qatar, but we'll get there. We've been here before. We've been to countries that were starless, and then within a few years, we've had them full of stars. And you can see where we've been in terms of Asia Pacific. You can see the stars in Japan, the stars in Europe, and the growing stars in Latin America. Next slide. So Professor Ferrari's already mentioned this. The first step is to use something called the best practice framework. It's available in Arabic, and what it does, it describes to you what a good service should look like at the organizational level. And it's a really good way to plan your service, because once you've planned your service, you should go back and see, well, if I run the service as I've designed it, will I be able to hit this? And it was perfectly acceptable to hit this at the bronze level rather than the silver and the gold. Just get on the map, because once you're on the map, you'll then have the drive and the motivation to improve, and you'll have the access to the resources to do this. So how do you get on the map? What is this getting mapped process? Next slide. So the first thing is to go on the Capture the Fracture website and then download the PDF questionnaire and then fill it in depending on your healthcare system. It seems like a long process, but actually you can use your responses to help build your proposal to your decision maker at the hospital level or regional level to justify the type of fracture liaison service you want to have. When you complete and submit your form with data, it's marked green as in progress, and then we assign a level of achievement. And even if your FLS is very small and maybe only been running for 3 or 4 months, please do submit your form, because we can give you what we call a blue star. A blue star are our birth stars. They're the FLSs who've just started and are so hungry to get on the map. We put them on the map, but the expectation is over the next year or 2 years, they'll go from blue to bronze to silver and gold. And it's so satisfying to see blue stars come in, because we will give you feedback when you submit your blue star on the key steps you should focus on in terms of improving your service as effectively and as efficiently as possible. And then finally, your star is put on the map that you've already seen. Now, there are a number of resources that are available to you, and I'll show this on the next slide. So on the right, we have the core resources. We have what we call the FLS implementation tools, and these are all freely available, and we want you to read them. We want you to copy them. We want you to use them on your business cases. There's no point doing a literature review of the benefits of FLS. We've done that. You can just put that straight into your application. We have a mentorship program where we can give you mentorship advice on a one-to-one basis, or set up workshops such as this. We've already mentioned the best practice framework at the organizational level. If you have an FLS and you really want to show the data to your providers or decision makers, we've also set up patient level key performance indicators you can use. We have lots of slides on presentations, and they're very useful to look through and use to inspire you to make your own presentations when you're trying to align other key stakeholders to your process. We have the implementation toolkit, which has PDFs and Word documents of all the business cases that you can easily adapt. And we have a wealth of webinars. This will be one of them. There'll be other webinars as well that focus on things like monitoring, identification, how to complete the best practice framework, as well as other aspects of FLS care, such as lifestyle and treatment recommendation. And finally, we have our global patient charter, which you can ask for your societies and helps you put Qatar on the map as an affiliate, as a national society that's really pushing the global message. I've just put two new tools we're developing that are part of a wider initiative called the Capture the Fracture Partnership. So as I mentioned, we are developing this FLS benefits calculator at the national level, and currently we have Japan and Netherlands very soon, and then Spain on our target list. And you can then talk amongst yourselves to see if this level of economic data is required by your policymakers and whether you think it's useful to have a model made for your own country. And then finally, working very hard with the team at IOF, we've developed the FLS digital tool. Tracking patients, as Serge has already shown you, is very challenging. They come through different services, they need to be monitored, and you must make sure your service, as Serge says, doesn't stop at the front door of the hospital. So we made a patient tracking tool that's very easy to use, and it can be translated in other languages, and will help every FLS become more effective and efficient as soon as possible. And as I've said, all these resources are available for mention on the Capture the Fracture website, and do get in touch with Anastasia if you want more information. Next slide. So in summary, we've had great presentations. We'll leave enough time for questions. We've talked about the burden, the Qatar perspective, the model of FLS and its implementation in Geneva, and briefly supporting tools. I'd now like to, here are our contact slides, and open it up for questions, Serge.
Yes, thank you again, Cas. Thank you, Dr. Abdullah. And we're here to answer your questions for the next 10 minutes or so. So Anastasia, what are the questions that you've been addressed?
So the first question is the following. What is the optimal time to start osteoporosis treatment after fracture?
Can I answer that? ASAP, as soon as possible.
Now, Serge, what about the 2-week wait for Zeledronate? Do you want to give your thoughts on that?
Well, there is the myth and there's the reality. Okay, I think that if you take into account the paucity of the data showing the need to wait 2 weeks or more after a fracture with any drug, with the reality, which is the every day that you wait after a fracture to start the therapy is one more day where the patient is likely to get out of the hospital, and you're going to lose it forever. So really, I think you need to convince your orthopedic surgeon colleagues that it is more important to initiate than to wait a day or a week or a few. And we've absolutely stopped waiting to initiate ZOL or any other therapy. We do it as soon as possible, certainly before the patient is released from the hospital. As I have shown to you, if you defer therapy, the likelihood that the patient will have therapy and be adherent at 6 months is much, much less. So the sooner the better. Cass, you agree?
110%. If I could, I would start it with this as they come out of the operating theatre or as they're admitted. The 2-week wait is really not substantiated, and as Serge has so elegantly presented, the sooner you start, the sooner they'll stay on, because the patient understands this might happen again. That's why I'm having the treatment. And when they've got a painful arm or a painful leg, they will stay on. And you'll link the treatment to the outcome you're trying to prevent much better than if you wait 3 months when they've forgotten about the fracture, how painful it was.
Anastasia, next question.
Thank you. Sure. So please specify the time for zoledronic acid, denosumab, and teriparatide if there's a difference.
We already said as soon as possible after the fracture. Next question.
Should we wait for BMD to be done to start treatment, or can we start treatment if it is a low trauma fracture?
Gas for you.
Oh, so as Serge knows, I think bone mineral density has a very important role to play in osteoporosis. But when you've already had the outcome you're trying to prevent, waiting for DEXA doesn't often change treatment. We have a number of tools that already can put people at high risk. And what we're finding is these tools are underestimating imminent risk. So for example, in the States, having a hip fracture or a spine fracture over 65 equals treatment. There is no DEXA recommendation. And we are in the UK and in some centers, we are now not assessing fracture risk if you've had a humerus, a pelvis, a hip, or a spine fracture. And it's going to become more common. As Serge mentioned, every day you wait, you're just leaving them unprotected. Serge, what do you want to, anything to add?
That, which is to say that in Switzerland we have the same recommendation. If it's a major osteoporotic fracture, like the one you mentioned, particularly of course vert and hip, it is an osteoporotic fracture, deserves therapy. The DEXA can be done, should be done in the hospital, or if you can't, then outside and see the patient back as the starting point for the efficacy of your therapy, for monitoring, but not for prescription purposes. Now, of course, there are other types of fractures, clavicles, ribs, or even wrist in a younger patient, where the DEXA will be necessary to make sure it is osteoporosis. But remember that for the major osteoporotic fractures, the DEXA is not essential. Actually, 3/4 of your major osteoporotic fracture will have a DEXA above -2.5. So if you wait for a DEXA, you're just going to be confused. Treat the bone fragility, not the DEXA. Next question, Anastasia.
Sure. So we know that osteoporosis is an orphan condition, which family medicine, rheumatologists, endocrinologists, and geriatrics are following up and treating. What will you do to work as a team with other specialties to make sure that work does not overlap? And how can you make the patient's journey better?
Well, I sort of
mentioned that, and then I'll give it to Cass. Excuse me, Cass. There's two questions in the question. Okay, it is a multi-specialty specialty, and then you need to distinguish what happens in the hospital and what happens outside. As I showed you in our own FLS service, for example, it is a teamwork between the service of bone disease, the geriatric department, and the orthopedic department. So we obviously need to work together, and personal contacts are essential to establish this group that will take care jointly of the patient. Now, if the question is with regard how do we manage that with our colleagues that are not in the hospital, the multiple specialties, I think the UK model has something to say here, Gav.
Yes, I mean, you just need one champion. It doesn't matter what specialty they are, and you need to form your coalition. And as Serge has said, Serge is an endocrinologist, I'm a rheumatologist, we are on the same page here. We have the same model to deliver. It just so happens in the hospital that's a setting. And we in the UK did work very hard to make sure the Rheumatology Society, the Endocrinology Society, the Geriatric Society, the Orthopedic Society, and the Trauma Nurse Society all said FLS is a priority. And once all those societies have agreed, most doctors are so busy, actually finding the champions quite hard. And I'd love to have a hospital that had 2 FLS champions. Actually finding someone who will stay the distance, as the Geneva FLS has shown, and have that resilience to deliver is so key. So I don't mind who's involved. The duplication issue is just by getting all the people to agree this is the pathway. And it can be delivered by different people, but as long as you have that team mentality from the beginning, and they're involved from the beginning, you will avoid duplication.
Hope we answered the question. Anastasia?
Sure, next question. You start treatment for osteoporosis even if the vitamin D levels are suboptimal?
It's an interesting therapeutic question. I think that it's a good one. Particularly, I imagine in the Middle East and in Qatar, where vitamin D levels can be really low. So it depends on the treatment. Or I would agree that if you have very low vitamin D levels, you would probably defer initiating the potent anti-resorptives until you have corrected that. So maybe 2 or 3 months. That is also actually why, as you saw in our FLS, the assessment of the basic bone biology is important, not just to discover secondary causes, but to eventually detect the severe vitamin D deficiency that then, yes, would need to be replaced for a couple of months, I would say, before you start your anti-resorptive therapy. Cass, you agree?
Yeah, I completely agree. I think what we do is we layer off the people with osteomalacia, because that's different. And if they've got a very high alk phos and it looks like they've got osteomalacia, we layer them off. For the orals, we co-prescribe, so you start the oral with the vitamin D replacement. But for denosumab, zoledronate, and teriparatide, we only give a month actually. We fill them up with calcium and vitamin D over a month. Keep going with the high dose vitamin D after that. But we think after a month of high dose therapy with vitamin D, at the bone level, there should be some response and also some improvement.
Can we ask Dr. Abdullah and Alemadi here in Qatar, what is your practice to replenish vitamin D in those patients with insufficiency? You give them a high dose or just a progressive daily supplementation? How do you do?
Actually, what is available in Qatar and the hospital is the vitamin D2, the 50,000 international unit once per week, but also we do have the D2, the daily 1,000 international unit. So it depends on the patient and we stratify, and then accordingly it's a mutual decision between the patient and the physician. What do they prefer? But also we do have the available of 300,000 international units intramuscularly and the 600,000 international. But recently, actually, we are gonna replace all the vitamin D2 that we do have with vitamin D3 in the hospital. Because we found that D2 absorption in a lot of patients, it's not working. So that's why we are going to replace all our stock with D3. Just maybe next month it's going to be available for everybody.
And so how would you do when you have your patient with a fracture and severe vitamin D deficiency? You would first give them one of these loading doses, and then how much would you typically wait to initiate osteoporosis therapy?
2 to 3 months, actually.
Yeah.
So you load them with the vitamin D, and then you just start the treatment afterwards.
So we're all on the same page. Thank you,
yes.
Thank you, Samar. Anastasia, next question.
Sure. Since the first step is hip fracture identification, what is the preferred agent that you start for hip fracture?
What is what?
The preferred agent that you start for hip fracture.
As a therapy? Well, I guess
think so, yes.
Okay. Well, in our case, the treatment by default is Zol, zoledronic acid, because it's actually the only drug that has grade A evidence in that context. They are the only ones who had the courage to run a post-hip fracture trial. Notwithstanding the fact that in many cases, because these are all patients with some level of renal insufficiency, etc., it's sometimes not possible, and so other treatment options from oral bisphosphonates to denosumab are also prescribed in that context. But I would say by default, it's often zoledronic acid. I don't know how it is in the UK, Cass.
Yeah, so in the UK, we're much more driven by costs. So in centres that are very cost sensitive, they use orals, but given the long onset of benefit, we just like you. So we use denosumab or Zol because we need to de-risk these patients rapidly. And, you know, if they're very high risk, then they sometimes get anabolics.
Anastasia, we have 1 minute left. So I guess one question left.
One more question, absolutely. So the Hamad Medical Corporation has many hospitals in different areas. What is your suggestion to have a central FLS or FLSs in different areas?
Well, I'll let Cass and then maybe Dr. Abdullah comment on that.
Yeah, I think COVID has taught us that actually remote identification and assessment is actually reasonable. And monitoring can definitely be done centrally. It doesn't require local implementation. And the biggest driver is numbers. If you have hundreds of patients in a center, then it's worthwhile filling that up with one nurse. But if you're going to look at like 10% of a nurse in one center or 10% of a nurse in another center, far better to have a full-time nurse just doing this than delegate it to other staff. But what do the local KOLs think?
Dr. Abdullah, what's your thoughts about that? Centralized or decentralized FLSs in the case of this hospital network? Can't hear you.
I don't see Nabil. I don't hear him actually. But from a logistic point of view, I'm just going to take this over that we are going to do it centralized because the number of cases are not that much huge, and we don't have the enough manpowers to have them in different areas, and we need to standardize things. So first of all, it has to be centralized, standardized, that it is up to the the standard internationally, and maybe later on, after maybe 5, 6, or even 10 years, if we are doing our job really perfectly, then we can teach and train other remote areas. But I don't think that it's going to be uncentralized. I think centralized is the answer for this.
Well, I just want to add to that we have, for example, regions in Switzerland where they don't have a major university hospital, but they have like a regional hospital, and then a bunch of smaller hospitals that take like trauma surgery on a first come, first served almost. And exactly as you said, Dr. El Ahmadi, in that case, to have the main hospital centralize the cases for the management. It is a challenge because distance makes referrals even more difficult, and you may lose even more patients in the way. So that's perhaps where what we've learned with COVID by how handle our virtual lives more efficiently is gonna play a main role. So the virtual FLS is something we need to maybe develop further, Katz.
Oh,
yeah.
we're already there. We're already fully virtual.
Well, thank you all. I think we come to an end and a close here. It's been a fantastic opportunity for us to present you this program. And this is just, I think, the beginning of a journey we're going to make together, particularly through the huge expertise of Professor Javaid here, who's going to continue to lead the Capture the Fracture initiative for the IOF. Thank you, Kaz. Thank you, Anastasia. Thank you, Dr. Abdullah and El Ahmadi, sharing your experience. And we'll see you back soon for further webinars. And we're always there to help you implement your FLS program. Take care and very good day.
Thank you, everyone. Bye-bye.
Thank you.
Thank you.
Thank you. So I'll just do a quick conclusion. So first, I would like to thank the speakers for their excellent presentations. It is now time to conclude the webinar, but if you have any further questions or if you need any further information, please feel free to contact us at IOF. We have an email address that is dedicated to the Capture the Fracture program that you've seen on one of the slides that we showed at the end. So the email is capturethefracture@iofbonehealth.org. A short questionnaire will be sent to you immediately after this webinar, asking you for your feedback. We would very much appreciate any comments as we continuously try to deliver webinars that meet your needs. And on behalf of IOF, I would like to thank you all for your participation this morning, and I hope that you enjoyed this session. Goodbye and have a lovely weekend.
Bye-bye. Anastasia, do we stay on?
No, I'm closing it now. Thank you
Okay.
very much to you all. Thank you.
I'm going to send you a quick email that needs your attention today. Is that okay, Anastasia?
Absolutely. Yeah, I'm free.
I'll send it to you now. Okay.
Okay,
Serge,
perfect.
masterclass.
Good job, guys. Well, great.
Well done.
Take care. Good day. Bye-bye.
Bye. Have a lovely weekend.
You too. Thank you.